Hello everyone, we will presentation our discussion about what is consultation and the example consultation case. Our group consists of Ade Irma Ayuning Tias, Eldania Putri Regina Aurelia, Anindya Putri Razak, and Kaurenisa Nurul Fitria. Consultation. Consultation is the act of seeing assistance from another physician or healthcare professional for diagnosis study, therapeutic intervention, or other service that may benefit the patient. There are several levels of consultation: single visit consultation, continuing collaborative care, and transfer to primary clinical responsibility. Their description as are follow. A single visit consultation involves examination of the patient or the patient medical record and performance of diagnosis tests or therapeutic procedure. The finding, procedure, and the recommendation of the consultant are recorded in the patient medical record or provided to the practitioner with the primary clinical responsibility for the patient in a written report or letter, and a few may be charged. The subsequent care of the patient continues to be provided by the referring practitioner. Examples of such consultation are confirming the finding of the pelvic examination, performing a specific hemodynamic procedure on a patient with urinary stress incontinence, and interpreting an electronic fetal monitoring, tracking, or imaging studies. In a latter two cases, the tracing of the other output can be transmitted electronically, allowing for the performance of a single visit consultation without personal contact between the patient and consultant.
Continuing collaborative care describes a relationship in which the consultant provides ongoing care in conjunction with the referring practitioner. Thus, the consultant assumes at least partial responsibility for the patient care. An example is a high-risk obstetric patient with a medical complication of pregnancy who is periodically assessed by the two consultants, whereas the referring practitioner is responsible for the day-to-day management of the patient. Transfer of primary clinical responsibility to the consultant may be appropriate for the management of problem outside the scope of the referring practitioner education, training, and experience, or in case in which the patient must be transferred to another facility. Examples are the transfer of care of a patient in preterm labor from a birth center to a consultation in a prenatal center, or referral of a patient with ovarian cancer to a gynecologic oncologist. In many of these situations, patients will eventually return to the care of the referring practitioner when the problem from which the consultation was sought is resolved.
The consult request could be in a letter or on a form, or it could be a statement in the medical record. Sending a copy of the consult note meets requirement of submitting a report back the requesting physician. However, also include a cover letter summarizing thought because consult notes are often lengthy. Even though sending a cover letter is good for patient care and appreciated by colleagues, there is not a formal requirement for this according to the rules. Seeing a patient in consultation does not prevent the consultant from ordering diagnosis, studies, or from seeing the patient in follow-up. In chronic diseases such as diabetes or thyroid cancer, often our recommendation will include advising the patient to return. Consult requests are sometimes ambiguous. A request stating "refer to endocrinology for recommendation on osteoporosis" is more than likely a consult, even despite the word "refer" being used. However, the following request, "consult to use management," may be interpreted as a referral because it is a request to use some care. When in doubt, contact the requesting physician to clarify. However, the reimbursement for doing the same work is less for a medical referral than a consult. More importantly, there may be problems if ever audience and the medical record does not support billing consultation. Responsibility of the consultant can be outlined as follows. 1. Consultants should recognize their individual boundaries of expertise and provide only those medically accepted services and technical procedures for which they are qualified by education, training, and experience. 2. When asked to provide consultation, the consultant should do so in a timely manner and without regard to the specialty designation or qualification of the referring practitioner. 3. The consultant should effectively communicate findings, procedure performed, and recommendations to the referring practitioner at the earliest opportunity. 4. A summary of the consultation should be included in the medical record or sent in writing to the referring practitioner. 5. The extent to which the consultation will be involved, the ongoing care of the patient should be clearly established by mutual agreement of the consultant, the referring practitioner, and the patient. At the time, it may be appropriate for the consultant to assume primary clinical responsibility for the patient, even if this is only a temporary circumstance. The consultant should option the referring practitioner cooperation and assent whenever possible. 6. When the consultant does not have primary clinical responsibility for the patient, he or she should try to option consultants for minor procedure or additional consultant from the referring practitioner. 7. In all that is done, the consultant must respect the relationship between the patient and the referring practitioner, being careful not to dismiss inappropriately the patient's confidence in her other caregivers. 8. The consultant should be cognizant of the referring practitioner abilities, and the consultant and referring practitioner should discuss who can best provide the agreed open care. Reliance on the referring practitioner abilities may increase convenience to the patient, limit transportation needs, and ultimately result in more cost-effective care. In other cases, however, it may not be possible for the consultant recommendation to be addressed adequately by referring practitioner. 9. If the consultant believes that the referring practitioner is not qualified to provide an appropriate level of continuum care, the consultant should recommend to the referring practitioner and, if necessary, to the patient that the referring practitioner transfer care of the patient.
Case. Patient. My stomach hurts, twisted and felt nauseous. For a while continued to twice and not anymore. I quiz why doctor. Nausea and abdominal pain are symptoms that are often related to each other and that cause many people to visit health facilities. Halah, facility.